everyone. Welcome to this new episode of Ask Stago, the podcast from Stago. This platform is dedicated to answer the questions that you may have about our products or hemostasis in general. My name's Lisa Gannon and I'm Global Product Manager here at Stago, and I'm so glad to join you here today. To animate today's session, I'm joined by Anne-Cécile Ortega, also Product Line Manager at Stago for Lab Automation Solutions. Hi, Anne-Cécile.
Hi, Lisa. Hi, everybody.
So today initiates the start of our Back to Basics series, where we will discuss the clinical utility of the three most common parameters tested in the lab, the PT, the APTT and Fibrinogen. Today, we're going to cover the Prothrombin Time.
Yes, Lisa. And to cover the topic with us, we are glad to welcome our US colleague, Dr. LaShanta Brice. Dr. Brice, it's a pleasure to have you with us. You are a scientific engagement and clinical education scientist, so you're really well placed to cover this topic with us today.
So, Dr. Brice, can we start with the basics? Could you provide us with a brief overview of the pathophysiology of the prothrombin time?
Sure. Hi, everyone. The prothrombin assay evaluates the extrinsic and common pathways of the coagulation cascade, which are essential for forming a stable fibrin clot. The process begins with tissue factor, a protein released by damaged endothelial cells. Tissue factor binds with factor 7, activating it to factor 7A. This complex then triggers the conversion of factor 10 to 10A, initiating the common pathway. Factor 10A, along with factor 5, calcium, and phospholipids, converts prothrombin into thrombin. Thrombin is a key enzyme that cleaves fibrinogen into fibrin, forming the structural framework of a clot. The prothrombin test works by artificially initiating this process in a controlled environment. In the laboratory, a patient's saturated plasma is mixed with tissue factor, calciums, and phospholipids. The time it takes for a fibrin clot to form is measured in seconds, which is normally a range around 10 to 14 seconds.
Okay, and why would an order for a PT test be received by a lab?
The PT test is a cornerstone in evaluating blood clotting function and is frequently ordered in several key clinical scenarios that are monitoring anticoagulant therapy, evaluating bleeding disorders, assessing liver function, detecting vitamin K deficiency, preoperative screening, and investigating disseminated intravascular coagulation. But of course, these are not all the clinical scenarios it could be used for.
Could you elaborate on maybe some of the other scenarios that it could be used for?
Sure. When we talked about monitoring anticoagulant therapy, there is a specific anticoagulant that we are looking to monitor with this test, and it is known as warfarin. More specifically, many laboratories in the North American market have standardized this test to using the international normalized ratio. This is used to give dose adjustments to prevent both thrombosis and excessive bleeding. The other bleeding disorders are more specific. We can look at things like factor deficiencies and or liver disease as an underlying issue.
Okay, and could you describe maybe some emerging trends in the US considering the INR clinic?
As we see advancements in laboratory medicine and patient care models, INR clinics have now evolved into anticoagulation clinics to improve efficiency, accessibility, and patient outcomes. With that, other emerging trends include point-of-care and telehealth expansion. In both scenarios, portable INR meters are being used by patients to help with managing specifically warfarin. Many times patients are not able to report into the hospital to actually receive on-site care. So remote monitoring allows real-time dose adjustments while reducing in-person visits. In addition, we've now seen the introduction of artificial intelligence at a high level to help clinicians fine-tune some of the dosing based on genetic factors, diet, and their own specific personalized INR trends to help improve safety and effectiveness. For patients that are not going to continue with warfarin, they have started to shift towards being prescribed direct oral anticoagulants, which don't require INR testing. In addition, new care models are shifting INR management to pharmacists and nurses, improving access to patient care and outcomes. This is especially important in underserved areas. Lastly, there has now been the integration of the INR into chronic disease management. We see this as a bundle with cardiology and internal medicine to help streamline care for patients specifically with arterial fibrillation and venous thromboembolism.
Okay, so perfect. So now if we start to talk about the PT assay itself, could you describe some of the limitations associated with the PT assay?
While we've mentioned several times that PT testing is a key tool in coagulation assessment, it does have a set of limitations. First, the prothrombin assay only evaluates the extrinsic and common pathways, meaning it won't detect intrinsic factor deficiencies like those seen with hemophilia A or B. Second, reagent variability can impact results. While the INR standardizes warfarin monitoring, it's not valid for all coagulopathies. Additionally, prothrombin assays may appear normal in mild deficiencies or early liver disease and disseminated intravascular coagulation, which limits its sensitivity. It's also not reliable for monitoring direct oral anticoagulants, and heparin contamination can falsely prolong the results in the absence of heparin inhibitors. Finally, sample collection errors like improper tube filling or the presence of hemolysis can impact some assays. To overcome these limitations, Prothrombin Time is best used alongside APTT fibrinogen factor assays to provide a full coagulation picture.
Okay, and what feature should we take into account when selecting a PT reagent?
Selecting the right reagent is essential for giving clinicians clinically meaningful results, but they have to be taken into context of the patient population being served. Factors that a laboratory and its professionals could consider would be sensitivity to factor deficiencies. This can be accomplished by reviewing the International Sensitivity Index. This determines how sensitive the reagent is to a factor deficiency. A lower ISI provides greater sensitivity. Another thing to take into consideration may be the thromboplastin source. Prothrombin reagents use tissue factor, a source of thromboplastin, but that thromboplastin could come from a recombinant source or from rabbit. The reagent itself will also be a factor to take in consideration. Lyophilized reagents oftentimes have a longer shelf life. However, liquid ready-to-use reagents can help improve flow efficiency, but they do have a shortcoming of having a shorter stability. As we discussed earlier, heparin tolerance is important for patients that transition from warfarin onto heparin. Some prothrombin reagents contain heparin neutralizing agents to help reduce interference from residual heparin in samples. And finally, the last part is very important to laboratories, and that is the ability to provide lot-to-lot consistency, as lot-to-lot variation can affect results, which may impact patients that are being monitored for warfarin.
So thank you so much, Dr. Brice, for this conclusion and this very interesting session with us. I have been so pleased to learn more about this topic, and I'm sure our listeners will feel the same. As usual, all our literature sources and links to previous podcasts will be listed in the podcast description box. And please do feel free to send us any questions that you may have at our email address, ask@stago.com, and we'll be happy to address any questions in our following episodes. See you next time.
This podcast is brought to you by Stago. Diagnostics is in our blood.